Welcome to This Week in South Carolina. I'm Gavin Jackson. Healthcare costs continue to rise. Several rural hospitals have closed, and South Carolina continues to rank near the bottom when it comes to overall health of its citizens. But the release of a new cancer report and a rise in medical technology shows there is reason to be hopeful. South Carolina is ranked 36th in the country for healthcare by U.S. News. Things like medical access, healthcare quality, and public health factor into the score. Despite being ranked the 14th most obese state and having fewer rural healthcare facilities, a new report looks at cancer rates in South Carolina as a bright spot for the Palmetto State. The South Carolina Cancer Alliance released a 20-year trend report on incidence, mortality, and survival, which showed more people are surviving lung, breast, prostate, and colon cancers in South Carolina. The only cancer that has seen increased mortality rates is melanoma, the skin cancer that is the fifth most commonly diagnosed cancer. Not all cancer can be prevented, but there are steps people can take to limit their risk. Regular checkups for those with a family history of cancer are important, as are lifestyle factors such as limiting sun exposure to unprotected skin, quitting smoking, drinking alcohol in moderation, eating healthy, and being physically active. Chronic diseases like cancer, heart disease, and diabetes are the leading causes of death and disability in the United States, and treating them account for 90% of the nation's $3.3 trillion in healthcare costs, which are covered in part by ever-increasing insurance premiums that continue to climb to record levels. While insurance costs continue to rise, the amount of rural hospitals in South Carolina has shrunk, in places including Bamberg, Winnsboro, Bennettsville, and Barnwell over the past 9 years. And a shortage of primary care doctors exists in every county except one in our state. Meanwhile, nurse practitioners and physician's assistants have been approved to provide more services to fill the increasing gap. Joining us to discuss the state of healthcare in South Carolina is Dr. Ramala Petrosan, a South Carolina Medical Association resident, fellow physician, and also an American Medical Association delegate. And from the Arnold School of Public Health at the University of South Carolina, Dr. Anthony Alberg is here to discuss the 20-year cancer report. Thank you both for being here.
Thank you, Gavin.
Dr. Alberg, I want to start off with you looking at this big report that came out. Tell us some of the top-line numbers that we saw in this 20-year study. I just want to mention one of them is that we did see the mortality rate decrease by 18%. So it sounds like some good news in this report.
There is some good news. So I would start by just saying, we all know that cancer is a fearsome disease, and so many lives have been touched of South Carolinians and nationally. Friends, family members have likely been touched by all the viewers by cancer. And one of the tools that we use to tackle cancer is to have public health surveillance to track the occurrence of disease. And we're very fortunate here in South Carolina to have an excellent cancer registry that provided the data for this report. So we now have 20 good years of data, and you're correct. The news is very favorable overall. We see a small decrease in the risk of developing disease, about 3%, and about an 18% decrease in the risk of dying from cancer overall. So I think that reflects the work of many. There's been a big national investment in the war on cancer, and so prevention, screening, and medical treatments have all contributed to this decrease.
Mm-hmm. So when we look at that prevention, screening, obviously I think one of the big factors too is the reduction of people smoking cigarettes as well?
Yes, so if we look at the causes of cancer, we now know that cigarette smoking causes about 48% of all cancer deaths in the United States. Many people know that smoking causes lung cancer, but it actually causes 13 different kinds of cancer, and so takes a major toll on the cancer burden. And the fact that smoking rates have been decreasing is a major contributor to this. So anything we can do on the prevention side is really going to decrease the amount of people who develop the disease and therefore die from the disease.
And when we talk about those rates, there's still some big numbers, unfortunately, behind those rates. 26,000 people a year in South Carolina are diagnosed with an invasive cancer, and nearly 10,000 die from the disease. Those are pretty sobering, terrifying, and frankly annoying numbers that we have to deal with. And we all know someone affected, like you're saying. What can we do? What can these viewers do at home who are watching do to help maybe prevent their chances of becoming diagnosed or dying from cancer?
That's a great question, and we now have, based on the advances in understanding of cancer causation, we now have many tools at our disposal. Cigarette smoking is one of them, so preventing children from ever taking up cigarette smoking is a big benefit, and any addicted smoker can lower their risks of developing cancer by quitting at any time in their life. It's never too late, and there's good therapies available, medical therapies as well as counseling for people who need help to do that. That's also a policy area where our legislators can help by increasing cigarette taxes, increasing the minimum legal age of access to cigarettes is something many states are doing nationally, and we should definitely take a look at. Other risk factors, alcohol drinking is a major risk factor for several cancers. So the guideline is to minimize, if someone drinks alcohol, to not drink too much. It's 2 drinks a day for men, 1 drink a day for women is the recommended maximum level there. Avoiding ultraviolet radiation, so that's sunlight or from tanning beds, is a way to prevent skin cancer. And one of the sobering messages in this report was the increase in melanoma skin cancer is increasing in South Carolina, and that's a way we can tackle that. Other ways to prevent cancer, there's now infections can cause cancer, and we now have a major cancer prevention breakthrough with the availability of an HPV vaccine that can prevent several different types of cancer. Unfortunately, in South Carolina, the uptake of that vaccine has been far too low. So we really need to educate our parents and our youth to have that vaccine routinely administered in pediatric practices. So those are some of the weight management is another big issue. So a cross-cutting risk factor for many types of cancer is obesity. So maintaining a healthy weight is also very important. And then diet has been looked at extensively. And I think the take-home message for me that I would take from a very large body of evidence is that it's pretty clear people who eat more fresh fruits and vegetables have a lower risk of developing cancer.
So a lot of good messages there, and we'll get back to talking about cigarette smoking a little bit with lung cancer. But doctor, I want to ask you a little bit about this too. When we look at those numbers, 26,000 people a year diagnosed, that's 26,000 people a year that are having conversations with doctors like you about cancer and their diagnosis. What's it like, you having these discussions with patients that might have a blip on a CT scan or something like that? What's the reaction been? Are people feeling more optimistic these days because of the advancements in treatment and maybe catching it earlier, screening?
Absolutely, and it's really the reaction that we're getting from patients is very variable and is very dependent based on their level of medical knowledge or understanding, or potentially having a family member or a friend who has been diagnosed with a similar condition before, and they sometimes know what to anticipate. With the new advances that have really come out in this arena, there is definitely a lot more hope in terms of really specializing and identifying the individual genetic markers that may identify certain types of cancers, and then finding biomarkers that can be used to be for more individualized targeting of cancer. And for us and even the oncology specialist, is always very difficult to determine what the expectancy would be for a patient. So it's because of so many different therapies that are now coming out, and the advances that we've seen. And previously, the expectancy of colon cancer was less than a year, and now we're looking at approximately 2.5 years, and it might be even longer depending on the new medications that are coming out, and more immunomodulating medications rather than chemotherapy, for instance.
Yeah, because with breast cancer too, I mean, you can detect, with that, if you have a family history, obviously, but also genetic markers are really helpful in determining your risk factor for developing breast cancer as well, right? Is that one of maybe the reasons we've seen maybe a decline perhaps in some of these?
That's a great question. So breast cancer is a really interesting example where you're seeing a contribution of factors to lower the mortality rate. In fact, we don't have a lot of prevention strategies for breast cancer, but it's early detection, so mammography screening, and the technology continues to evolve for imaging the breast and detecting lesions early. You mentioned genetic risk for cancer. cancer. And I think that's very important because we talk about prevention, but not everybody's at the same risk from birth. So we have germline or inherited mutations that might be present that really predispose to cancer. And BRCA1 and BRCA2 genes are ones where there's known mutations that confer a high risk for breast cancer. So getting tested for those, if one's from a family where there seems to be a lot of breast cancer risk, seeing about getting the genetic testing done, and then going under more active surveillance for detecting the breast cancer early is a major tool. And there's been dramatic decreases in breast cancer mortality. That's a contribution of the screening, and it's also a contribution of the advances in treatments that Rommel has been mentioning.
I kind of just want to go back to something you said, Dr. Ahlberg, about melanoma. I mean, we saw these rates drop in all these other cancers except melanoma, and it's increased by, what, 6.5% of men, 22% of women. This study started in 1996. People started knowing about the benefits of sunscreen and what you need to start doing, and sunscreen's become more and more prevalent in a lot of our daily products. What do you think is driving this increase in melanoma if we know that we're at increased risk of exposures, skin cancer, and people are dying at the rate of 146 a year? Is this something we just don't think about? Oh, I'm only in the sun for a couple minutes a day, no big deal. Or I got one sunburn, no big deal. What's the miscommunication here?
I think it's a great question, Gavin, because you're assuming that everyone understands that information, and I don't think we're doing a great job in terms of getting the message out for what the risks of sun exposure are. We live in a society where being tan is valued by many, and that leads to incentives to go to tanning bed salons and expose oneself, and that's part of what's driving this increased risk. That's particularly among white females, younger, teenage, adolescent, young adult, and there's policies that can be taken to limit access to tanning beds by age and to make sure that there's warnings for anybody who's using tanning beds. That's a major risk factor. And then getting the message out. I think parents of young children are an important target group for the message to start early in life with protecting an infant and young child from overexposure to the sun, including sunscreens, avoiding sunlight at the peak hours, and sun protective clothing, and so on. And then particular, it's not everyone's at equal risk of skin cancer. It's some people who burn easily and are more fair complexions would be at greatest risk, and they're the ones that we really need to be reaching with these prevention messages.
Yeah, it's not like my mother's generation when they were outside, just getting that full blaze sun on the face with iodine on their skin to get darker. I mean, we know better than that these days, but it still is kind of disconcerting to see those rates going up. And I did want to stick with you, Anthony, about kind of looking at another fascinating data point from the study that points to a huge drop in mortality rates for black men when it comes to cancer and them surviving better. They still have high rates of mortality, but they're surviving better. So I'm wondering, when you see something like that, how do you incorporate that into maybe what you take away from this entire report, what you do with this trend data overall?
That's another great question, Gavin. So we did break the rates down by population subgroups, particularly male, female, black, white, and then the real story emerged when we broke it down by gender and racial ethnic group. So black males is the group that you're asking about now, and I should say that the news was favorable for all those groups overall, mostly. That we saw downward trends for the most part in all those groups. So that's the good news. The bad news is that the rates in African American men were highest to start back in the late 1990s, and despite the declines experienced by all groups, they remained by far the highest in African American males now, and so that's very concerning for why that is. And to me, one of the take-home messages is it's not all about racial ethnic group either, because in fact, the risk of developing cancer was lowest in black females. So it's not entirely about race. Now that's the risk of developing cancer. Black females did have higher rates of mortality than white females. So, but I think what we're doing with this, so in public health, we're action oriented. We look at the data and inspect these findings, and then we're called to action. So what's happened now is the African American males are going to be the source of a new report that's going to be released in about a month from now. That's under the leadership of the South Carolina Cancer Alliance, and I would just mention that group if any listeners are interested in helping in the fight against cancer in South Carolina. That's a very worthwhile group, and all are welcome at the table in that group, whether from oncologists down to cancer survivors to interested community members. We're interested in getting everyone involved. But in that report, we're drilling down more what cancers are driving those higher rates, and thinking about planning for what needs to be tackled. What information do we need to really identify the root causes and therefore address the inequities around this?
So doctors, that's something maybe you also take away from this study too. You see this trend data and you talk to your patients, and you might be talking to a black female or a white female, but it's maybe difficult to get more males to see doctors. I think that's kind of the average overall traditional problem. So is that something you say, hey, you should talk to your husband about this or your brother because he might be at a greater risk for developing lung cancer because they still have high rates? I mean, is that what you guys do when you see data like this as well?
When seeing data like this, I think it really encourages us to ask more of those questions whenever we're seeing our patients, learning more about them. We ask about their family history, asking them about various social factors that might contribute to their potentially developing cancer. Sometimes we do screenings, for instance, for colon cancer. Everyone who's 50 years old or regardless of their family history should have a colonoscopy. And that's a recommendation that we really strongly encourage, and whether it be the patient that we're seeing, it's definitely a conversation that we have with them to then encourage their family members to come in. And sometimes if they have a very trustworthy and wonderful relationship with us, they're more likely to then bring in their other family members into those visits.
Especially if you have family history and all these worrisome issues. And I want to kind of jump back to lung cancer because I'm interested, with vaping coming on the scene now, this, I'm guessing, wasn't a big factor in this report at the time because this ended, 2015, 2016? So I'm interested to see what we'll be seeing going forward because, obviously vaping is seen as a way for smokers to kind of quit smoking. There's also data that shows that smokers also vape and smoke cigarettes at the same time. And we're also seeing an increase in teenagers getting addicted to nicotine through vaping. A whole generation of teenagers that wouldn't have smoked cigarettes probably otherwise are now getting addicted to nicotine. So I'm wondering, doctor, are you guys paying attention to that, especially when we look at lung cancer rates and those rates dropping? Could there be potential for them to start rising in the future?
So that's a really interesting question, and in asking it, you really raised the complex issues around this. So aside from the current outbreak of severe respiratory illness that we're in now, which complicates matters even further, there's the whole issue of youth vaping versus the potential of vaping as a smoking cessation device that could help people to quit combustible tobacco cigarettes. So let's focus on the youth first because I think that's getting at the long-term implications of your question. So I think CDC has a great message, the Centers for Disease Control and Prevention, around vaping. Safer doesn't mean safe. So what do we know about e-cigarettes? We know that they contain toxic metals that cause cancer. We know that they contain a host of chemicals other than nicotine, the health effects of which are unknown but have a toxicity profile that would lead one to believe that there are long-term health risks, and that includes even short-term biomarkers, increased oxidative stress, increased inflammation, like you would see with combustible tobacco cigarettes, but less. And that's the key here, that there are toxins in these products. They're not safe, but the idea is that they're potentially safer than combustible tobacco cigarettes, and likely to be so, even despite this outbreak we're in. So you've got youth getting addicted to e-cigarettes, And then the big question is, well, what happens to them with relation to combustible tobacco cigarettes? In my mind, that's been the big question. And there's a clear answer to that question now. Youth who use e-cigarettes, who've never smoked cigarettes, if you compare youth who vape versus non-users of any tobacco product, youth who vape are 4 times more likely on average to go on to smoke combustible tobacco cigarettes. So right there, that seals the deal for me. It's not a winning situation. Aside from the health risks of vaping itself, aside from the nicotine addiction and the adverse effects to the developing brain, you're also getting a pipeline of a generation of new smokers. And you can therefore, we can all draw the inferences what that means to long-term lung cancer rates. And remember those 12 other cancers also caused by cigarette smoking.
And I want to incorporate smoking, but a different form of smoking. Medicinal marijuana is obviously a big discussion we've been having in South Carolina. They're still trying to debate this legislation that's been stuck in the State House for a while.
Yes.
Still seems bogged down, not really too optimistic for where it might go next year. But Doctor, what are the benefits that we do see in some other states that have legalized it? Or what's the motivation, I guess, from medical professionals to say, hey, you know, this is another form of treatment that can help people with pain from cancer?
Absolutely, and there have been medical studies that looked at chronic pain, that looked at nausea from chemotherapy, that looked at spasticity from multiple sclerosis as kind of one of the potential conditions in which marijuana may be helpful. The South Carolina Medical Association doesn't really is not for or against medical marijuana. What we really are trying to emphasize is we need more studies and more robust clinical data to actually make appropriate decisions and whether to recommend this to patients or not. Within the FDA, marijuana is classified as a Schedule I drug, and there are some medications, for example, Marinol, that has been approved by the FDA for treatment of anorexia in AIDS patients. So that's appropriately dosed medication that has been studied and we know has proven some effectiveness. So we're not against prescribing Marinol, but we're wanting to actually have more information on whether this would be safe for patients. As physicians, we all sign a note to do no harm, and if we're going to be recommending or prescribing a medication, we would need to know what kind of interactions it might have with other medications that they have, whether it can have some adverse effects on their mental health and have addiction potential down the line. And a lot of those questions we don't have the full answers to. And it's also very difficult to dose marijuana. And that's really the aspect of it. For each prescription we write, there is a particular dosage, a particular maximum, and side effects that we anticipate, but that's very difficult to actually say about marijuana at this point.
So a lot of different tools in the arsenal there. But we have about 5 minutes left, and there's so much more to talk about the state of South Carolina healthcare. But one of the interesting things I found while I was doing this, I mean, because we're talking about cancer, we're talking about chronic diseases, and there's several other chronic diseases that contribute to 90% of the nation's $3.3 trillion in healthcare costs annually are attributed to chronic diseases like cancer, like heart disease and diabetes. So I'm wondering, you know, again, we talked about what needs to be done, but then there's also the direct correlation to why our health insurance premiums keep going up. And I'm wondering, Doctor, you know, are people putting this together? Are they realizing, hey, maybe we need to start living healthier lifestyles because we're all paying higher insurance premiums? I just saw that the average cost of health insurance for a family costs $20,000 a year. Employers pay most of that, but people are pretty much paying like $6,000 worth of that. It doesn't seem sustainable when we look at overall growth of insurance costs and, you know, healthcare costs, because yes, we might be surviving longer, but it's expensive to treat these chronic diseases.
So I think that's an interesting question, and I can't speak to a lot of the details, but I guess there has been, through the Affordable Care Act, for an example, incentivized preventive care. So there were incentives and good reimbursement for cancer screening, something we've talked about, for smoking cessation, counseling and medications. I think incentivizing the preventive side would reap large dividends down the line.
Yeah, and we also see from the AARP that 27% of adults under 65 have stopped taking medications because of cost. So what do you know, when we look at the South Carolina Medical Association, what are they trying to maybe push with their legislative agenda when it comes to prescription drug costs. I know some states are looking at boards to overlook what's driving these costs up.
And that's definitely on our agenda for the year 2020 to take a closer look at that. We don't have a specific stance on that at this point. I'm also on the Council of American College of Physicians, and I know that currently they're also working on a movement to envision a better healthcare system for the United States. So on the ACP side, I know it's in the works, and we're hoping to take a better look at it from the SCMA side as well.
Really quickly, I mean, I'm wondering how rural healthcare is also being affected here because hospitals are closing. Are we seeing, again, maybe people making the decision maybe not to drive to the hospital because of being so far away and there's no longer a rural hospital in their town, perhaps? Can anyone speak to that?
Well, I can tell you that's a really good question because rural cancer care within the cancer community, oncology community is a major priority now. It's really come to the at the radar screen at the federal level to the National Cancer Institute that there are disparities that occur in the rural setting, and how can we address that issue? So I think it's a problem. I think it's and the current healthcare environment is working against that in a way, but I think with attention being paid and use of telemedicine, telehealth devices and so on, that we can appropriately reach out. But again, it's going to take a data-driven, intentional strategy to help solve that problem.
And we've, to add to that, we've also had legislature looking at physician assistants and nurse practitioners and really revamping their ability to actually reach out to those areas as well. There is no longer a geographic limitation to physician assistants that are being supervised by a physician. There is an agreement regarding scope of practice that they would have to come together with their supervising physician that then would have to be accepted by the Board of Medical Examiners to move forward with
So yeah, a lot of movement there on the state level too. And also, so just the big takeaway message, be active, stop drinking, stop smoking, be active, and eat right, guys. Thank you so much. From the Kennedy Greenhouse Studio on the campus of the University of South Carolina, I'm Gavin Jackson.